My name is Axel Grothey. I'm the Director of GI Cancer Research and Chair of our Molecular Tumor Board at West Cancer Center and Research Institute in Germantown, Tennessee. And I would like to talk to you about updates in GI malignancies. Here are the topics we need to discuss. It's pretty heavy on colon cancer because there was a lot to learn and to integrate in our clinical practice in colon cancer. But I will branch out to gastroesophageal cancer, discussing the Matterhorn study. First of all, can exercise improve colon cancer outcome? This was a very interesting trial and has implications for our clinical practice, how we discuss lifestyle changes with patients. So this was a Canadian-Australian study, patient with early stage colon cancer, stage 2, high risk, or stage 3. Were actually randomized after baseline fitness testing, almost 900 patients, to a structured exercise program, meaning they got a personal trainer and health education materials, or just getting health education materials, how you should kind of lead a healthy life and how you should exercise. And the structured intervention led to a difference in disease-free survival. This is colon cancer and mortality, the recurrence and mortality of colon cancer. And for every 16 people, exercise prevented one person from recurrent or new cancer. And at 5 years, the difference was almost 6.5%. That is remarkable, and it translates into a difference in overall survival. Of course, with the added healthcare benefits, of exercise in general. At 8 years, there was a 7% difference in overall survival. Now, when we put this into perspective, kind of in context with other kind of more pharmacological interventions in cancer, you see it really the absolute overall survival gain really compares very favorably to what we consider for granted, like adjuvant oxaliplatin in colon cancer, trastuzumab in breast cancer, etc. You see it here on this slide. Now, this is one part of lifestyle changes we can talk to patients about. What about aspirin? Aspirin has been around as a potential prevention of secondary colon cancers for quite some time. And there were actually interesting data that linked the benefit of aspirin to patients with colon cancer that had mutant PIK3CA. That's one of the proteins in molecular pathways that we can test for whether this protein is mutated or not. So there are preliminary data in retrospective studies which showed aspirin use was beneficial in patients that had these PIK3CA mutations. And this Scandinavian study now had a prospective randomized intervention in these patients that had these PIK3CA alterations, and they were able to screen 3,500 patients and found about 1,100 patients that had these alterations. 37% of patients do have these PIK3CA mutations and alterations. So they divided it up in two different groups depending on their pathway. And then each of these groups were randomized to take aspirin at 160 milligrams daily for 3 years or placebo. So that's about two baby aspirins. And the interesting results published just about recently in New England Journal was that the use of aspirin, 160 milligrams per day, 3 years for 3 years, really decreased the risk of recurrence or death by 40 to 50% in this subgroup of patients with the PIK3CA mutations. So that is a very substantial reduction of recurrence events. So my conclusions here, we have very intriguing data that have to influence our lifestyle discussion with patients after adjuvant therapy. I sit down with patients after they complete adjuvant therapy and talk to them, what else do we need to do? And the magnitude of benefit is really in line with a lot of things that we take for granted, like oxaliplatin. If exercise was a drug, it would be FDA approved, it would be exercisumab, whatever, and covered by insurance and Medicare. So we need to encourage patients to exercise. There's a lot of healthcare benefits. And why don't we give aspirin to all patients, irrespective of this PIK3CA? If you can't test for the molecular parameters, which we normally don't necessarily do in the early stage setting, the toxicity and the financial toxicity of aspirin is very, very safe. These data actually empower patients. They can do something to lower the risk of recurrence. Now let's talk about optimized therapy for early stage mismatch repair deficient MSI-high colon cancer. This is one of the conundrums that we have. We didn't really know how to pursue, perioperative adjuvant therapy in these patients for quite some time. The atomic study presented by Frank Sinekroop from Mayo Clinic was plenary session, actually very prominently featured at ASCO this year. And they used in mismatch repair deficient stage 3 colon cancer standard, whatever standard is, FOLFOX for 6 months, which is likely overkill because of the duration of therapy, which is too long, with the PD-L1 antibody atezolizumab added as the experimental arm, atezolizumab for a whole year. So 6 months parallel to FOLFOX, and then another 6 months atezolizumab single agent. Primary endpoint was disease-free survival, and you can see here the treatment exposure. And I want to highlight that these patients really got 10 cycles of FOLFOX, which, as I mentioned before, based on the IDEA data, that we can now, for a lot of patients, use just 3 months of CAPOX instead of 6 months of FOLFOX, is definitely a little bit on the long side. Now, primary endpoint was reached. The addition of atezolizumab to FOLFOX improved outcome by about 10% absolute at 3 years, and this reduced the risk of recurrence by 50%. So that is really remarkable, the hazard ratio. Overall survival are not mature and likely confounded by the fact that when patients have progression of disease, they will receive immunotherapy now, which is standard of care, and these patients actually in stage 4 can still be cured. We'll talk about this later. Now, peripheral sensory neuropathy is the issue here, and I really don't like to see that patients, about 20% of patients had grade 3, 4 sensory neuropathy, which is a big issue. Now, the question, of course, is how big of a blast is atomic now that we know that these patients with mismatch repair deficient MSI tumors actually do respond to immunotherapy? And, Miriam Chalabi, who is the kind of discussant at the plenary session, made a very good point. In metastatic mismatch repair deficient colorectal cancer, we do not even use chemotherapy. We use either pembrolizumab or a combination of ipilimumab and nivolumab, and we'll talk about these data in a minute, but we do not use chemotherapy. And as you can imagine, chemotherapy is the more toxic component of the adjuvant treatment here. If you really embrace the so-called atomic schedule of patients with stage 3 disease receiving adjuvant chemoimmunotherapy now. In addition, the Dutch group actually had, under the lead of Dr. Chalabi, had a very interesting neoadjuvant treatment data. So these were patients who were diagnosed with mismatch repair deficient colon cancer based on immunohistochemistry, and that's what we do routinely in our patient that gets diagnosed with colon cancer, even early stage. So they received 2 doses of immunotherapy, 1 dose of Nivo-Ipi, 1 dose of Nivo, and within 6 weeks, they went to surgery. And you can see here, 2/3 of patients had a pathologic complete response with just 2 doses of immunotherapy, and there was a 3-year disease-free survival rate on the right-hand side. This is a survival curve of 100%. We can't do better than that. So this is not a randomized comparison, but this is more than 100 patients followed over more than 3 years. So my conclusions here, yes, of course, we need to test for mismatch repair deficiency. We need to have a multidisciplinary discussion how to manage these patients. And I believe you can't get better than 100% with very limited preoperative treatment. So if possible, preoperative IO therapy, Nivo-Ipi followed by Nivo, 2 doses is preferred. Then if we see, let's say you have a patient that had resected stage 3 disease, you might want to obtain circulating tumor DNA to look at whether there's some evidence of minimal residual disease, because then you could make a case, there's still cancer left, and you could use IO therapy, immune therapy with Nivo-Ipi or Pembro. And again, we'll talk about that. I do not administer 6 months of FOLFOX. I don't believe this is justified in these patients where we know that chemotherapy doesn't even work. And then my concern is also that atezolizumab is not the strongest immunotherapy agent in the management of colon cancer. And, based on the data that we have now, atezolizumab is locked in at 12 months. We probably do not need that much and that long of immunotherapy, and potentially not even chemotherapy at all. So this is an area which really requires discussion in the multidisciplinary team, taking all the data that we have into account. So what is the best immunotherapy for metastatic mismatch deficient MSI colon cancer? We still didn't know whether PD-1 antibody like Nivo or Pembro would be appropriate or whether we should add ipilimumab to PD-1 antibody. The Checkmate 8HW study actually clarified the situation. This was a three-arm study, 2 to 1 randomized. The control arm was, standard FOLFOX or FOLFIRI plus minus bevacizumab or cetuximab. And the first comparison was Nivo-Ipi versus chemotherapy. You can see there's a big difference in progression-free survival. You can drive a truck through this. There's really no reason to give give chemotherapy as first line. It has a ratio of 0.21, means almost an 80% reduction of progression events when you use Nivo-Ipi. And you can see this trends almost like a plateau. I do believe we can cure some patients with immunotherapy in stage 4 disease. Now, what about the contribution of ipilimumab? Can we get away with Nivo alone? And the study also compared Nivo-Ipi versus Nivo. Nivo here as a green and Nivo-Ipi in red. You can see the addition of CTLA-4 antibody for a short time in the initial phase of the study, not continuously over the course of disease, was able to improve outcomes for patients, has a ratio of 0.62, meaning almost a 40% reduction of progression events. And my conclusions here, first of all, of course, we need to test for mismatch repair status. That's mandatory. Now, we have two options for IO therapy. We have pembrolizumab or nivolumab single agent. You saw the data for patients where you do not believe they would be candidates for ipilimumab. But the stronger and probably standard of care right now is Nivo-Ipi. It really also avoids what we saw in the Pembro study, the Keynote 177, the early crossing of the PFS curves, that initially chemotherapy might be a little bit better. We don't have data available for Nivo-Ipi in overall survival. There's definitely crossover from chemotherapy, but I believe, it's very difficult to argue that this is not standard of care. All subgroups appear to benefit. So this is our way to individualize therapy for first-line immune therapy. Now, let's make a difference in BRAF V600E mutant colorectal cancer. BRAF mutant colorectal cancer, V600E mutated colorectal cancer, they have the worst prognosis. Overall survival, before we had these targeted agents targeting the BRAF biology, was less than 12 months in metastatic colorectal cancer. And these patients have a very unique metastatic pattern. They have peritoneal disease, retroperitoneal lymphadenopathy, a lot of liver metastasis. So they're definitely poor prognosis. Now, we know that a combination of encorafenib, a BRAF inhibitor, and cetuximab, or panitumumab for that matter, in a second-line treatment is beneficial. That was the Beacon study, which was formally published a few years ago. Breakwater now used this concept of using a BRAF inhibitor, encorafenib, and cetuximab in first line. So this is first line metastatic BRAF V600E mutant metastatic colorectal cancer. Combination of encorafenib, cetuximab as one arm, which was closed earlier because there was clear evidence, that it was not as effective as encorafenib, cetuximab in combination with FOLFOX. That's one of the arms here. And standard of care was kind of whatever investigators thought, a chemotherapy, a doublet, of a triplet, plus minus plus minus bevacizumab. So primary endpoint was progression-free survival and response rate, and secondary endpoint was overall survival. And here's the primary endpoint. That's encorafenib and modified FOLFOX6 plus versus standard of care. You can see the difference is very profound. Median progression-free survival is more than a year. This is where we normally saw overall survival with a standard of care. Hazard ratio for progression-free survival 0.53, meaning a 50% reduction of progression events on the study. This is the comparison of the combination of chemotherapy plus targeted agent versus standard of care. And this translates very nicely into an overall survival. Overall survival 30 months. 30 months with the combination of encorafenib, cetuximab plus FOLFOX, doubling overall survival, median overall survival compared to standard of care. This is the new standard of care. So there's no doubt that modified FOLFOX6 plus encorafenib and cetuximab should be considered for these patients in first-line BRAF V600E mutant tumors. And of course, we need to test for BRAF V600E in all patients. Now, interestingly, when you just use the encorafenib cetuximab arm without FOLFOX, there might be some patients who are not candidates for chemotherapy. This is actually an overall survival trend between the FOLFOX alone arm and the experimental arm, encorafenib, cetuximab, and FOLFOX. So if you really have a patient who is not a candidate for oxaliplatin-based therapy for FOLFOX here, you could even make a case for encorafenib, cetuximab. Again, survival is not as good as with the combination with chemotherapy, but it is there. And you see higher response rate with the combination of targeted agent plus FOLFOX and duration of response more than a year. Again, this is very, very profound. The toxicities you have, I mean, the addition of encorafenib, cetuximab to FOLFOX doesn't really add too much of it. In particular, since FOLFOX is clearly the dominating part, inducing the side effects. You see more rash. Of course, you have cetuximab here. You have arthralgias, but otherwise, not a lot of difference compared to what you see with FOLFOX alone. Now, my conclusion on breakwater is, previously we had BRAF V600 mutant tumors with very poor prognosis, and the combination now using encorafenib and EGF receptor antibody added to FOLFOX is the new standard of care in first line. Higher response rate, longer duration of response, prolonged progression-free survival and overall survival, turning it into a much more manageable disease. I mean, 30 months median overall survival in these patients was unthinkable not too long ago. And it's an interesting concept. We know that V600E is a very strong driver of biology. So the data really support the idea of targeting a strong oncogenic driver as early as possible. We know this in breast cancer with HER2. We like to target HER2, which turns a poor prognostic marker into actually something that gives us treatment options for patients. And the research now needs to focus on mechanisms of resistance. When and why do these patients eventually progress on therapy? What happens and how do we counteract that? Now, moving from colon cancer to gastroesophageal cancer, and I want to move from ASOPEC to Matterhorn. What do I mean with that? So the ASOPEC study was actually presented at the 2024 ASCO plenary session, since then published in the New England Journal of Medicine. This shifted our standard of care in distal esophageal cancers from neoadjuvant radiochemotherapy with carboplatin and paclitaxel, the so-called cross regimen, to perioperative chemotherapy with FLOT, which is 5-FU, oxaliplatin, and docetaxel. 5-FU infusional 5-FU for 24 hours, not 46 hours like in FOLFOX. Keep that in mind. So it was perioperative chemotherapy versus neoadjuvant chemoradiation, surgery in between. And this set a new standard of care because the perioperative chemotherapy without radiation led to much better outcome in progression-free survival, and it did translate into overall survival. With a 3-year difference of about 7%, and this it became a new standard of care. Now, the new part now is adding durvalumab to this treatment, to the backbone of FLOT, 5-FU, oxaliplatin, and docetaxel, which was presented at ASCO, published in the New England Journal actually this year, the so-called Matterhorn study. So Matterhorn was a randomized phase 3 study, a global study, which looked at FLOT, perioperative FLOT, with the addition of durvalumab, for 2 cycles before and 2 cycles after surgery, added to FLOT, and then 10 cycles of durvalumab after completion of FLOT adjuvant therapy up to a year. This was placebo-controlled, and they did everything right, Asia versus non-Asia stratification factors. These tumors have different biology, lymph node positive, lymph node negative. And they looked even at patients that had a low PD-L1 expression score. They used a so-called TAP score, a tissue staining score, not the CPS score that we use for pembrolizumab and nivolumab in some Primary endpoint was event-free survival, secondary endpoint overall survival, almost 1,000 patients randomized. And primary endpoint here was reached, event-free survival improved with the addition of durvalumab to FLAUD, hazard ratio 0.71, highly statistically significant. And this did translate into overall survival improvement, even though yet it's not statistically significant because the threshold was set differently due to statistical considerations, but there's clearly a difference with the addition of durvalumab to FLAUD compared to placebo, hazard ratio 0.78, meaning a 22% reduction of death events on the study. And when patients underwent surgery and the pathologic CR rate was higher, 19% compared to 7%, we do know that these patients that have pathologic CR do better. Now, my conclusions on the neoadjuvant or perioperative therapy for esophageal and gastroesophageal adenocarcinoma is the ASOPEX trial briefly set a new standard of care for patients that were considered for chemotherapy for FLAUD. And when I said briefly was because, yes, we moved from chemoradiation for distal esophageal cancers to chemotherapy perioperatively, but no matter how, added durvalumab to this treatment with benefit in event-free survival, pathologic CR, and also trend at least for overall survival. Even patients with cancer with low PD-L1 expression levels benefited. The added toxicity of durvalumab was very minimal. So this is my summary for this year with major advances in GI cancers, focusing mainly on colorectal cancer. I hope you take away that you educate patients about the use of exercise, aspirin. I think there's really no downside for the vast majority of patients to take aspirin as adjuvant, part of the adjuvant lifestyle change therapy. There are very interesting data in mismatch repair deficient colon cancer. Think about neoadjuvant immunotherapy for those patients that get diagnosed, that you avoid giving chemotherapy for those patients. An area that I haven't talked about, briefly touched upon, is mismatch repair, is minimal residual disease, MDS, testing with ctDNA, with tumor-informed or non-tumor-informed tests, which really helps us identify patients who are at risk for tumor recurrence in early stage disease. So there's a lot happening right now in GI oncology, and I'm really excited about the things we might see in 2026. So please contact me if you have any questions. My email is here. Thank you very much.